Hey everyone, thank you for having me. My name is Tyler Crawford. I'm a second-year resident at West Florida Hospital, part of the UCF-HCA consortium. My presentation will be called the less typical aortic thrombus. So we had a patient that presented January 2021 with a 1-week history of nonspecific abdominal pain and non-lifestyle limiting claudication. This patient had actually previously been seen about 3 weeks prior for a GI bleed. Because she was COVID positive at that time. She was stabilized after 1 day in the hospital and discharged home with no findings. At that time, she did have a CT that demonstrated no acute processes, either bleeding or in the aorta. She went out to an outside GI facility where she underwent a repeat CT. Demonstrated a large infrarenal aortic thrombus. This, in combination with her symptoms, prompted them to tell her to come back to the emergency department for further evaluation. Background on her past medical history to that point had been significant for diabetes, hypertension, sciatica. She previously had spine surgery. She was not a smoker. On review of systems, she had flank pain radiating to the back, claudication, and no rest pain. On physical exam, she was neurovascularly intact. She had 2+ DP and PT pulses on bilateral lower extremities. She had no limb threat or evidence of embolization. On admission, she had a white blood cell count of 3.2. Her H&H, she had hemoglobin of 9, hematocrit of 30. Her platelets were 1.328 million, and her creatinine was 1.3. Here's a video of her CT on admission. You can see there her large aortic thrombus coming in. So at this time, vascular surgery was consulted for evaluation. Given her presentation, the acute nature of the thrombus, and her high platelet count, there's high index of suspicion for a white clot. And so options given were heparin drip, thrombolytics, open aortic surgery with thromboembolectomy, or percutaneous thromboaspiration. There was an extensive discussion held with the patient at this time about what they would like to do. Concerns were that she had a hypercoagulable state, an embolic event, cancer. There was a risk of progression with emboli, acute limb ischemia. And based on the elevated platelet count and otherwise, it was an asymptomatic thrombus. So after discussion with the patient, she elected to go with full dose anticoagulation with a heparin drip, aspirin 325, and hydroxyurea for the thrombocytosis, 2,000 milligrams daily. She remained in the hospital where she was asymptomatic throughout this time. She got a repeat CTA in 3 days that demonstrated no acute change in the size of the thrombus. Hematology was consulted due to thrombocytosis. They actually agreed with management and kept the dose of the hydroxyurea and aspirin. She underwent echocardiogram. It was significant only for grade 1 diastolic dysfunction. Then hematology sent a JAK2 mutation analysis to help further define her thrombocytosis. So because she was asymptomatic with no progression in the disease, the plan was established to have her follow up in the vascular surgery clinic weekly, with plan for a repeat CTA in 1 month. So she did follow up weekly. She did remain asymptomatic. She got a follow-up CT on 2/23 that demonstrated complete resolution of the aortic thrombus. At this time, she was deemed clear from an acute vascular surgery standpoint, and care was transitioned to hematology for treatment of newly diagnosed essential thrombocytosis with a diagnosed CALR mutation. From that point forward, reviewing documentation, she was intermittently compliant with the hydroxyurea and recently added on anagrelide, she said, due to unspecified side effects. And she was in for an unrelated incident in September of 2025, and CTA demonstrated no aortic thrombus. And here is her repeat CT from approximately 1 month later. As you can see, there's no residual thrombus at this time. So in her case, she was diagnosed with essential thrombocytosis, which is a myeloproliferative neoplasm with a platelet count defined greater than 450,000. Specifically, in her case, about 20 to 25% have a calreticulin mutation. And with these patients, they're primarily found in patients that demonstrate thrombocytosis. And interestingly, leukocytes are a stronger predictor of thrombosis than platelet count in these patients. Diagnosis often requires bone marrow biopsy as well as genetic testing is not sufficient. Long-term medical management of arterial occlusions in patients with thrombocytosis, in patients with thrombocytosis and increased risk of von Willebrand syndrome is centered around cytoreduction with hydroxyurea, with anagrelide less frequently used. Literature does recommend DAPT, dual antiplatelet therapy, but bleeding risk must be considered in patients who are older or higher risk otherwise. So in this case specifically, there was very little literature about essential thrombocytosis causing large aortic thrombuses such as these, as it typically affects microcirculation. And most reported cases presented with acute limb or bowel ischemia requiring intervention. There was a case report in 2001 from the Mayo Clinic proceedings that had a 45-year-old woman presenting with cramping abdominal pain and claudication, found to have a thrombus at the thoracoabdominal junction. She had pre-existing diagnosis of essential thrombocytosis, and the thrombus was believed to be a white thrombus in this case. It was treated with aspirin, 325 milligrams and 1,500 milligrams of hydroxyurea. This was actually fairly critical in the decision-making process for this patient, as this was pretty much the only case report in the literature that approximated her situation. And that patient as well got follow-up CT in 1 month that demonstrated complete resolution of the aortic thrombus and improvement in ischemic areas of the spleen and kidney. And those authors concluded that thrombi and essential thrombocytosis are more commonly white clots that will disaggregate with antiplatelet therapy and cytoreduction. And those are my references for this case.
Excellent presentation, Dr. Crawford. Thank you for sharing a very interesting case, and I suspect will provoke a number of interesting comments. It's just kind of fascinating how such a large burden of thrombus, where did it go? After a month, it's just totally gone. It's sort of anxiety provoking that, as it breaks up, it doesn't somehow embolize in a manner that causes some sort of end organ malperfusion down the legs, etc. And it looked like her internal iliacs were totally clean afterwards too. Sometimes stuff will trash into them. So it's sort of fascinating pathology in the sense that the antiplatelet agents will cause such a dramatic change in that radiographic appearance. I have a couple questions, and some of them I think you touched upon, and some I might have missed. So I know you mentioned she was presented with some claudication in addition to the abdominal pain. And I guess my first question is, do you think that the bout of GI bleeding beforehand, perhaps she was a little hypotensive, dehydrated, and in some sort of inflammatory state, and that is sort of what precipitated this event from triggering? And do you know at the time of that GI admission, when she was in the urgent care ER, what have you, what was her platelet count at that point? Was it abnormal or was it relatively normal? And then when she got the subsequent CT scan, was it then suddenly 1.4 or what have you? I'm not sure if you know that off the top of your head or not.
So when she initially presented, her platelet count was about 600,000. So it was elevated, but not as dramatically.
As to the degree. And then the follow-up to that then is also a month later when she had a repeat CT scan with such resolution and improvement, a month of treatment. What was her platelet count at that point?
So after about a month, her platelet count was approximately 1.3 million again. And when she had subsequently presented to the hospital a couple of years later, it was actually still over 2 million.
Wow. Wow. So it really, despite the treatment, that didn't really resolve the thrombus did. That's really interesting.
Yes, sir.
Tyler, that's a great case. I have a quick question. In all of your sort of preparation, Did you differentiate, sort of different locations? Sometimes we see this in the axial aorta more proximally. If you saw something in the transverse arch or the ascending aorta, and the risk of stroke to the brain versus something that's in the paravisceral or infrarenal aorta, is there any sense of the differences in natural history and subsequent risk and or the use of antiplatelet versus anticoagulation? I think obviously it's a primary platelet problem in this patient, and so you guys appropriately used cytoreductive therapy and antiplatelet strategies. Presumably, you would check the Plavix response assays as well. But I was curious if you found any differentiating features because this is sort of a patient with a primary aortic problem. They have a normal aorta with no underlying dissection, aneurysm, or atherosclerotic plaque, and they obviously have some underlying myeloproliferative disorder that predisposed them to this problem. And any differences that you could ask to delineate or teach us about in terms of proximal aortic lesions versus distal and whether or not their natural history and medical management should be different?
Yes, sir. So for the most part, the more proximal lesions I was able to find in the literature were all symptomatic, and they typically underwent some form of intervention, whether it be thromboaspiration or thromboembolectomy, anything of that nature. There was, I did not find anything that was analogous in terms of proximal lesions that were asymptomatic for these patients. Um, but it was fairly sparse literature for this particular kind of problem with these acute white clots.
Yeah, yeah. I
And
didn't
then
see any.
Tyler,
Go
oh,
ahead.
sorry, go ahead.
I was going to say the other question I think you asked was about you touched on the anticoagulation a little bit. I think that as the literature had evolved when I was looking through it, most of the recommendations were actually no longer including anticoagulation because it is a primary platelet problem.
Mhm.
But those did seem to have evolved throughout the last probably 15 years.
Another really quick question before we move on to the next presentation. Just curious, it was a little unclear. At what point did you actually get hematology involved? Did you all initiate the hydroxyurea, independent of them? Yeah, so that was my question, more or less.
Yes, sir. So the hydroxyurea was initiated independent of hematology. It was initiated on admission. And then hematology was consulted on admission, but they saw the patient, I think, day two.
Okay, so they were called upon arrival, more or less, when the.
Yes, sir.
Dean, I think there's a question from Dr. Taubman in the Q&A's area. If
Oh,
you
okay, I'm in the chat. Okay.
Yeah, not out of the chat. Um, I don't have that view to see that.
I just see that. Looks like Dr. Patel answered Dr. Taubman.
Oh, I see it. It says, was there right leg thrombus to explain the claudication, or was this attributed solely to aortic thrombus? I understand the patient elected for anticoagulation, but what were the operators leaning towards themselves? And good luck on your case. Did you hear that, Tyler?
Yes, sir. Um, and so, as Dr. Patel did mention in the chat, there was no thrombus anywhere else because it was a long distance claudication, and that it's just the aorta.
Why do you think it was unilateral claudication if it was a central aortic problem? I think that's what Dr. Taubman was referring to.
And
It sounded like in your presentation, maybe the right leg was only bothering her, or maybe we misheard that.
it was both
It was
legs.
okay, so it was bilateral. So
Yeah.
so you have a hemodynamically significant thrombus obstructing the central aorta, causing claudication. And then the other part of the question was, what were the operators leaning towards, even though the patient elected? Were you equivocal in your decision making, or were you initially leaning towards some interventional strategy?
And I can definitely jump in on that. So, the difficult with that case and how much thrombus burden there was in that infrarenal aorta, the concerns were, is this going to essentially just like a saddle embolus, all of a sudden one night she's going to wake up with bilateral acute limb ischemia and risk, potentially limb loss, versus open and endovascular therapy where manipulation in itself could cause distal emboli. And again, now you trash the feet, et cetera. So, literally, that's because of that platelet count, and because of that case report. I started hydroxyurea and cautioned the patient that, hey, this therapy could be wrong and we can be doing emergent surgery, but let's give it a try because you're otherwise asymptomatic. And she was agreeable to that. She was compliant with the medication early on, and she was compliant with seeing me in office once a week. And so, because of that, thankfully, everything resolved as you saw. But it was definitely that conversation was had in pretty much depth, as you can imagine.